Good day, everyone. Today we're going to look at the analysis of major COVID-19 treatment options. My name is Nishaad Mahabir.
I'm Sebastian Seepaul.
And my name is Ras Miller. Okay, we will start by discussing the reason we decided to analyze the different treatment options available for COVID-19. Since December 2019, the new coronavirus has infected millions and claimed the life of several thousand worldwide. Unfortunately, so far no approved vaccine or drug therapy is available for the treatment of virus infection. However, the Food and Drug Administration has approved the antiviral drug remdesivir for use in adults and pediatric patients for the treatment of COVID-19 requiring hospitalization. Cases that do not require hospitalization receive supportive care. Several different treatment options have also been considered, which we will elaborate on in the next few slides. The main motivation behind this project is to find the most effective treatment currently available for COVID-19. To determine the best treatment option, our team has gathered data from 150 different articles. We extracted data from the results table from each article and then converted these tables into meaningful graphics to analyze the data, as you can see on this page to the right. Okay, we will begin by analyzing the antiviral drug remdesivir that has been approved by the FDA. Due to the time constraint of the video, we decided to choose the two most representative articles for each treatment option. The first study was conducted to determine whether a 5-day or 10-day course of remdesivir would lead to better clinical results. The results show that there was no significant difference in efficacy between either time frame. Although the graph at the top might show a slight deviation in clinical improvement, the final outcomes were similar after adjustments were made. In another study, which is shown at the bottom, it was found that remdesivir did not significantly improve the time to clinical improvement. This can also be seen on the bottom graph, as I said before, which only shows a slight deviation between clinical improvements for the experimental and control groups. In the second study and a few other studies involving remdesivir, drug delivery was stopped early because of adverse events for patients in that group. The next major treatment option we will discuss is convalescent plasma therapy. In the first study, shown by the graph at the top, and several other studies which were analyzed, it was found that convalescent plasma substantially reduced all-cause mortality in the treatment group compared to the control group. As the graph at the top shows, convalescent plasma therapy substantially improved patients' survival and significantly reduced hospitalization period. This significant clinical improvement was also noticed in other convalescent plasma studies. It was also found that less patients require intubation in the experimental group. The graph at the bottom shows the safety outcomes of the second study that was analyzed, and the outcomes of this and several other studies indicate that convalescent plasma is safe for administration to patients with severe COVID-19.
The next treatment option we looked at was with the use of hydroxychloroquine and azithromycin simultaneously. We compared the data provided by the studies with data given with regard to standard care. From the upper graph, it can be seen that over the trial period of 21 days, hydroxychloroquine and azithromycin show a steady decline from the initial 735 population at risk to 568. This means that 167 people were removed from the population at risk within a 14-day period. Over the course of the next 7 days, the effects of this treatment show only slight improvement. Standard care, however, shows little to no decline in the number of persons at risk, as the number decreases only from 221 to 197, meaning only 24 people were removed from the at-risk population over the same 14-day period. It is expected that standard care will display a similar trend if an identical sample size to that of hydroxychloroquine and azithromycin was used. The lower graph displays the expected probability of survival for persons treated with both hydroxychloroquine and azithromycin, indicated by the black line, hydroxychloroquine independently indicated by the green line, azithromycin independently indicated by the blue line, as well as standard care indicated by the red line. Over the treatment period, we see that treatment with both medications show an increase in probability of survival by approximately 0.1 to 0.15, which is 10% to 15% in comparison to standard care. Another possible solution we came across was through the use of lopinavir and ritonavir, which we also compared to standard care for COVID-19 patients. From the upper graph, it can be seen that over a 28-day trial period, lopinavir and ritonavir shows a greater clinical improvement in comparison to standard care by 4% at day 7, 15% at day 14, and 8% at day 28 of a sample size of 199 patients. 99 of these patients used the medicine while 100 did not. Although these numbers are quite small, especially at day 7 and day 28, they show some promise in moving towards a more effective solution. Of the 199 patients analyzed, 44 died. 57 of the patients who died were receiving standard care, while 43% were receiving the trial treatment. This is represented in the lower pie chart. As such, it is possible to assume that lopinavir, ritonavir would be effective in lowering the mortality rate of COVID-19.
And next, we have a comparison between favipiravir and arbidol. Each patient considered in this study took at least one dosage of the respective drug. The main signs and symptoms for enrolled patients were pyrexia, fatigue, dry cough, expectoration, sore throat, diarrhea, and insomnia, none of which were significantly different between the groups. For this study, a total of 45 patients were treated with both favipiravir and arbidol. After 14 days of hospitalization, patients treated with favipiravir showed somewhat bigger improvements in health with less adverse reactions. As we can see from the first graph, there were slightly higher percentages of patient chest CT scan improvements on day 4, day 9, and day 14, respectively. In the second graph, we see that there is a higher number of patients with adverse reactions to arbidol as opposed to favipiravir. There was no significant difference of basic characteristics in patients between the two groups. Despite having slightly better results, we conclude that favipiravir does not show superior efficacy compared to arbidol. Favipiravir is associated with significantly shortened latency to relief for cough, while arbidol was shown to have a direct antiviral effect in early viral replication in vitro studies for COVID-19. For future works, in order to develop a definitive cure in treating COVID-19, more testing will need to be done. More experimentation will be required in order to minimize and account for the drawbacks of each presented treatment technique, and risk assessment regarding each treatment will also be necessary to provide a cure safe for distribution amongst affected population. Conclusion. Amidst all health safety protocols, people continue to become infected with and even succumb to COVID-19 daily. As discussed, treatment with convalescent plasma seems to provide the best results. Favipiravir and remdesivir are two alternative pharmaceuticals also proven useful in treating persons for COVID-19. Additional research must be conducted in order to provide a safe and effective cure for COVID-19.